Kia ora koutou, welcome to our ENT webinar for 2023. One thing I love about New Zealand is our relatively small medical community, and though currently we probably wish it was double, and as often we meet or re-encounter doctors we've met before or what it feels like in a different life. One of my colleagues recommended Justine Bradley, our speaker tonight, and she kindly agreed. And it wasn't until we met by Zoom and spoke that it dawned on me that I had met Justine in Christchurch during my student years when she was a reg. Understandably, Justine has no recollection of me, but that's often the way when you're a junior and someone is your senior. So welcome, Justine. Thank you very much for being our speaker this evening. Justine is a consultant ENT or otolaryngologist in Christchurch. And our session tonight is organised by the Rural Health Department of General Practice, University of Otago, and is supported by the Division of Rural Hospital Medicine and endorsed by the Rural New Zealand College of General Practitioners for 1 hour of CME. At the end, please complete the evaluation form, and if you add your medical council number, then I will lodge your 1 hour of CME points for you. Now, every time I do this, one person is unable to be uploaded, and then I get an email. Now, it's too hard for me to let you know, but so if you look in a week and your 1 hour of CME has not been loaded, then please just lodge it manually yourself. So Justine and I look forward to an interactive session this evening. So if you have any questions, then please put it through into the chat and we will watch and monitor that and answer your questions as we go through. Otherwise, yes, just a reminder, please fill out the evaluation form at the end because I really love the feedback and want future ideas for further webinars for this year. So without further ado, I will hand over to you, Justine, and feel free to add any more info about you, and the floor is all yours.
Yeah, kia ora tātou, ko Justine Bradley, toka ingoa. I think you've probably introduced me well enough, Lucinda, thank you. So yeah, I'm a otolaryngologist in Christchurch and have got a special interest in vertigo. So I will, I think we should hopefully have plenty of time. So please, let's sort of put things in the chat if you've got questions as we go. First of all, I'm going to just talk about vertigo as a symptom, I guess, introduce that. Talk about how we assess people with vertigo and then go through some of the more common causes of it. But if you've got questions along the way, it's probably better to kind of ask them as we go so we can make it as interactive as possible over the webinar. So first of all, the first question, what is vertigo? And I think there's a bit of certainly patients will often come and say to me, oh, I think I thought I had vertigo. I got diagnosed with vertigo, but I'm not sure if it was. And so I think patients often have an idea that vertigo is a diagnosis or it's a cause of disease, but I try and remind patients that actually it's a symptom. And it's quite a vague symptom. It essentially just means, well, it's not vague, it's a broad symptom. It just means the hallucination of movement or the feeling that you're moving when the surroundings are not, or the feeling that the surroundings are moving respective to you. So it's obviously not related to a particular diagnosis, but it is distinct from a lot of other causes of dizziness. And this is often, I think, the first problem for all of us as clinicians seeing patients with vertigo or dizziness, trying to work out what it could be related to. Dizziness itself is a more vague idea, which is sort of impaired spatial orientation, but without necessarily that sensation of motion. And so, as we know, a lot of other things can cause dizziness, from high blood pressure or low blood pressure or cardiac issues, panic attacks, lots of other causes for dizziness. So trying to hone down whether it is vertigo or not can be quite difficult. So next thing, just to remind ourselves what we use to maintain our balance. So what we're interested in today is the vestibular system of the inner ear, but also we're using all these other systems, so vision, proprioception, sensation on your feet, and all of these other things integrate. So if you've got issues with any of these systems, it's going to have to make your vestibular system work harder. And then conversely, if your vestibular system's not working, it can have effects on these other systems as well. And then all of that is fed into the brainstem and brain, also with the connections with the cerebellum to give the picture of our balance or where we are in space. I just see that there is a couple of things on the chat. I don't know whether that was.
Oh no, that's
that's
just
if
me
you with
putting
the evaluation form.
Yeah,
Perfect.
yeah.
Close
Yeah.
that. I was just making sure everyone could hear me and stuff. So there was just really basic anatomy. And again, this diagram's not wonderful, but just to, again, remind ourselves of the broad anatomy. On each side and each inner ear, we have got the vestibular system, which is made up of the semicircular canals, of which there's 3. So the superior, also called anterior canal, the horizontal, also called the lateral canal, and then the posterior semicircular canal. So these are all related to angular acceleration or rotational kind of movements, and they're filled with fluid that shifts. Then in the center, I don't know if my mouse is pointing over there, but perfect. Yep. So we've got the utricle and the saccule that are sort of in the inner part. And these are more determined with linear acceleration and gravity. So they are sort of in the central part. And then the vestibular nerves convey the information from and to there. So we've got the superior vestibular nerve and the inferior vestibular nerve supplying their particular parts of it. And then the vestibular nerve itself is part of the vestibulocochlear or 8th cranial nerve. So obviously intimately related with the hearing organ as well. And then the information from there is conveyed to the brainstem and then into the brain and the vestibular cortex. And obviously that has its connections with all those other parts of the body that we talked about before. And this is paired, it's on each side. I don't know why for some reason it's not letting me. There we go. So vertigo happens when either there's an imbalance of input between the two sides or there's loss of input between the two sides. But the key with the sensation of vertigo is usually that implies that there's quite a abrupt change. So if you've got a really slow changing lesion or a slow growing lesion like a vestibular schwannoma, there's able to be compensation made from the brain and brainstem between the two sides. So people don't usually notice vertigo itself. But when there's a fast or sudden onset or relatively sudden onset condition, then that's when you'll feel the vertigo, which is usually described as a spinning sensation, but sometimes might be rocking or boat-like. And we see when we're examining the patient, the nystagmus, which I'll talk about a bit more later on as well. Their postural reflexes will be affected. So either they'll fall or they will want to lie down. And then it's often associated, as we know, with the nausea and vomiting as well. So the most common causes of vertigo, which I will talk about later on in the talk, is BPPV, and that is by far the most common cause of vertigo in patients. Vestibular neuritis, which can also be called acute vestibulopathy, Meniere's disease, and vestibular migraine. So that's what I thought we'd talk about. But if you guys have got questions about other more rare or other causes of vertigo, you're welcome to bring them to the end. So the next thing I was going to talk about is how we assess patients in general with vertigo. And the first question in the history, or which we can't always get the answer to, but we want to try and establish, is it actually vertigo or is it this more other kinds of dizziness? And if we're thinking that it's not vertigo, we may want to go down the cardiac route or measure their blood pressure or kind of go down a completely different track. But if it seems like it is vertigo, then we'll go on with the rest of the history and exam as I've got laid out here. So next thing I like to find out is it the first time they've had it or are they having recurrent episodes? So, I mean, obviously a recurrent episode has to have a first attack at some point, so it could still be one of those. But on balance, if it's their first and only attack of vertigo and they've never had it before, it often is vestibular neuritis, but you want to rule out those central causes, so strokes and tumours, things. If it's episodes, so recurrent attacks of vertigo, then BPPV will be the most common, which has specific features that we'll talk about in a minute. Vestibular migraine would probably be the next most common cause of episodes of vertigo that recur, then Meniere's disease. There's an unusual condition called vestibular paroxysmia, which is a wee loop of a blood vessel from the aortic artery, which can compress the vestibular nerve. So that can give someone sort of brief episodes of vertigo, but it's pretty rare and it's much less common than the other things that I've mentioned there. So once we've established that it's vertigo, that it's recurrent or it's the only attack, the next question is whether it comes on its own or whether it's related to particular head movement changes. And so this can be quite a tricky thing because any kind of vertigo, if you imagine you've got vertigo, it's going to be worse when you move because you're putting more strain on the vestibular system. So every patient with vertigo will say, yeah, it's worse when I move my head. But the question is it only brought about by moving the head, and it's completely fine when they've got their head in the neutral position. So for us to call it positional vertigo, which is usually BPPV, that means they have got no vertigo when they're in the neutral position, and they only get vertigo when they put their head in a particular position, which we'll talk about what those positions are. So hopefully that's clear. Let me know if I've sort of made that more confusing rather than less. Then moving on to the attacks, the duration makes a big difference or helps us to delineate the cause. So BPPV is usually lasting for seconds. So it's brought on by head movements and it usually lasts for 15 seconds or so, up to 60 seconds, as does the little neurovascular compression that I talked about. Migraine can last for kind of any amount of time. As you see, I've listed it there under all of the options. So that can last for seconds, it can last for minutes, it can last for hours, or it can last for days. So migraine kind of comes under every category. If you've got an attack lasting for minutes, it's usually migraine, but potentially posterior circulation TIAs. I think in practice, it's quite rare for people to get those without it quite quickly progressing to a stroke. So people don't often present with recurrent episodes of those for months. But it's another consideration, I guess. And then the more common episodes of vertigo, if they're not lasting for seconds, will be lasting for hours. And that's where we're trying to think about, is it Meniere's disease or vestibular migraine? Then if we've got vertigo that's gone on for at least 24 hours or for a day or more, if that's accompanied by particular other findings, including spontaneous nystagmus, that is this acute vestibular syndrome, which is usually where we're trying to distinguish between vestibular neuritis and strokes or tumours. Or MS or other kind of central lesions, but migraine can actually present with that as well. So just to confuse us. So that's the duration of the attack, whether it comes on with position changes. Then we want to find out about associated symptoms, because that again can help pin down which of these causes it is. So the different things we want to find out about is I'll do it in the order that I've got there. So pain anywhere generally is a bit of a red flag with vertigo. So most causes of vertigo that are benign or come from the inner ear should not cause pain. So if someone's got a headache, they've got pain in their neck or pain in their ear, that's often a red flag for it to be something serious. Of course, a migraine could give you a headache, so it doesn't mean it's definitely something serious. But certainly if they haven't had a history of migraine and they've got a new onset headache with vertigo, that would make me concerned. Pain in the neck can be a vertebral artery dissection that you guys may well have come across or heard about. Which is again a relatively rare cause of vertigo, often caused by led onto by heavy lifting or straining, or an injury, which gives you neck pain. And vertigo can give you pain in the ear as well. And then if you've got an acute ear infection with vertigo, that could be a complication of acute otitis media. So that's another red flag. So pain anywhere, kind of worry about whether it could be something more serious. Then the ear symptoms, which we would all ask about. For someone with vertigo, so hearing loss, noise in the ear, fullness in the ear, that can be a bit of a mixed bag, because Meniere's disease gives you these symptoms. So you get fullness, tinnitus, and hearing loss in the ear around the same time as an attack of vertigo, maybe before, during, or after, and that can indicate Meniere's attacks, which will usually last for a few hours. However, if they've lost their hearing with some tinnitus, the vertigo's gone on for a day or longer, that actually can be a sign of an infarct of the AICA artery, because the hearing territory is supplied by that artery as well. So that actually can be surprisingly a sign of a central cause, even though it's causing the hearing symptoms, or labyrinthitis. So that's sort of the inflammation of the inner ear, post-viral inflammation of the inner ear, can give you those as well. Migraine symptoms, as we all know, that would point towards migraine. Neurological symptoms would clearly be a concerning cause for a central condition. Anxiety is kind of universal in people certainly with new onset of vertigo. So doesn't mean that it's secondary to anxiety. It's usually the anxiety comes because of the vertigo, but you can get vertigo because of an anxiety attack as well. It's also good to ask about trauma. As I talked about before, that vertebral artery dissection can relate from trauma or heavy lifting. But BPPV can come post-traumatic as well. So if they've had a bang on the head or bang on the ear and then had short attacks of vertigo afterwards, it could be post-traumatic BPPV. Fractures and perilymph fistulas would usually come from an obvious trauma. So the person's it's going to be pretty obvious that they've had some trauma with that.
Just a couple of things, Justine,
yes.
before you, just on here. So just regarding the greater than 24 hours one, is this essentially they have vertigo the entire time?
Yes.
Or is it like in waves? Or...
No, it's constant for 24 hours, yeah. So if it's in waves, if they've got
spinning the whole time.
They're constantly either spinning or feeling like they're moving, even if they've got their head still for 24 hours. And of course, it could be 23 hours or 36 hours. It's not exactly 24, but the research on this is based on 24-hour sort of cut off. So yes, if you've got vertigo on and off for 24 hours, that could be BPPV. But if it's constant,
Right, okay. Now, just to clarify, because we all love little letters, but that is your anterior
cerebellar artery. Anterior cerebellar artery.
There we go. See, this is why we ask these questions.
Yeah.
And then fullness. Can you just explain that more? So it's just that they
pressure in the air, like feels full, feels blocked, full pressure, that kind of thing. Yeah.
Okay, cool, good. Don't think there's any other questions, so keep going through from there. Thank you.
Cool. So I was going to go next onto the examination, but I guess should we just check if anyone wants to ask anything more about the history taking?
They'll generally put it in the chat.
They will have done
it. Yep, they will.
Perfect.
Yep, they're pretty well trained now. Cool. Seasoned campaigners now.
Oh, I don't know why. For some reason, it always doesn't want me to. Oh, there we go. So examination. So again, this sort of depends a bit how you examine someone. Depends whether you're in an emergency department or seeing someone who's presented acutely, or whether you might be seeing somebody who's come about recurrent attacks of vertigo and they're actually feeling fine today. So that definitely makes some difference about how you examine them. But I'm assuming for this purpose that someone's come with the vertigo that they've got at the time. And if that's the case, the first thing you want to do is look for nystagmus, because if they have not got nystagmus, if they say, I'm feeling dizzy right now while I'm looking at you and there's no nystagmus, presuming they haven't had heaps of suppressants, vestibular suppressants, then that kind of rules out an inner ear cause. It's not going to be a peripheral cause of vertigo if they've got it right now and there's no nystagmus. So that's when you think, okay, is it central? Is it a stroke? Or is it not even vertigo at all and they've got hypoglycemia or something completely different? So the nystagmus is sort of the first thing to look for in this acute setting. So in an acute peripheral loss, and remembering when I say peripheral, I'm meaning coming from the ear rather than brain or brainstem, what we should see is horizontal nystagmus. So it's going side to side, and I've got some videos of it, and it goes away from the abnormal ear. So if you've got a left vestibular neuritis, the nystagmus is going to be, the fast phase is going to be beating towards the right side. And it's always going to be doing that. So when I've written unidirectional, it means it doesn't change direction depending on any other factors. So when the patient moves their head or when they turn their head or look in different directions, the nystagmus must always be going in that same way. It might get worse or better. So what I've said there is that actually when you look in the direction of the fast phase, so let's say it's right beating, when you look to the right, it might get more obvious. And when you look to the left, it gets less obvious. When you fixate on something, so really try and focus, it might get less. And it might get worse if you put them in the dark or put these funny Frenzel glasses on. So those things should happen if it's peripheral, but it shouldn't be right beating and then left beating if they change their way they've got their head or their eyes. So that's kind of key, is that if it's coming from the inner ear, it should be horizontal, maybe with a bit of torsional. So it shouldn't be going directly up or directly down, and it should not change direction when they move their head or eyes. Central nystagmus. So the frustrating thing, it would be nice if that meant it was peripheral, and if it was central, it was completely the opposite. But unfortunately, central nystagmus can also be what we just said now, but it can be different things as well. So it can be vertical, it can be direction changing, it can be torsional. So if it doesn't follow those rules that I've got in that acute peripheral loss column, then it's definitely not peripheral. But if it does follow those rules, you can't be 100% sure. So basically never relax if you're seeing someone with vertigo is the message from this slide, isn't it? But it's good because there's other things you can do to help you. So that probably describes that slide pretty well. And then I've got some videos of that now. Hopefully they should work. Is that going all good?
Yep.
Cool. So I can play it twice, perhaps. So what we're seeing is this lady's got horizontal nystagmus. As she's looking at us, it looks like it's going to the right of the screen, but it's going to the patient's left. The fast phase is going to the patient's left. I'll play that one more time. So flick, 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 flick. The nystagmus is going towards the left.
So right-sided if it's, well...
Should be right-sided lesion, yeah.
If it's peripheral.
Exactly. And so then we're just going to show that what we call Alexander's law, which is that it gets worse when you look in the direction of the fast phase. So she's now looking to the left, which is the way that the nystagmus is going. And I think you can see that it gets worse.
Yeah. Yeah. Marked. Yep.
Yep. And then the next video is her looking to the right, so looking away from the direction of the fast phase towards the side of the lesion. And it is still there, but it's more subtle. It's not so obvious. Happy with that? Yep.
I am.
Good.
Everyone else's.
Yeah. So, I mean, I'll talk a bit later on about why the nystagmus does that, because I don't know. Sometimes I find it easy just to remember rules, and that's what it is. And sometimes I find it easier to understand why things happen. So I'll cover both aspects for people who like both ways.
Yeah, that's great.
But just to finish go through further things for the examination. So if we then see nystagmus, the next thing to do is the head impulse test. What I'll say here is the head impulse test is essentially testing your vestibulo-ocular reflex, which is a pathway it's a peripheral reflex. It doesn't go through the brain. It is sort of evolutionarily designed so that when we're running around, back in cavemen days, running around over uneven ground, keeping our eye fixed on our thing that we're trying to hunt, prey, we can, your head can move and the body can move, but your eye can stay fixed. And so it needs to be very fast so that you don't have to wait for the brain to catch up. And so essentially a head movement is accompanied by an equal and opposite eye movement using this reflex. So the key with the head impulse test is you only want to be using this in someone that's presented with vertigo and spontaneous nystagmus. Because what we're looking for in someone in that situation, which we've talked about before being this acute vestibular syndrome, so we think is it vestibular neuritis or is it a stroke? If it's a stroke, this reflex is going to be fine because the reflex is downstream from where the pathology is, which is in the brain. If it's vestibular neuritis, so if the pathology is in the inner ear, the reflex is going to be bad. It's going to be impaired. So what we are looking for to be reassured by this patient, to be reassured that they haven't got a stroke and they've just got a vestibular neuritis, is an abnormal head impulse test. Does that make sense? So what you don't want to do is do this head impulse test in someone who has hypoglycemia or low blood pressure, because you'll get a normal one because they haven't got anything wrong with the inner ear, but they also haven't had a stroke, but their reflex is working fine. But you might falsely think, okay, they've got vertigo with a normal head impulse test, it's a stroke. So the key is that they've got to have nystagmus so that you're thinking it's already something along those lines. It is, I think that is can be quite confusing. And it might become a bit more clear when we talk about vestibular neuritis itself. So to actually assess this reflex, the head impulse test reflex, what you want the patient to do is to look at something about 1 meter away, which is conveniently your own nose when you've got your hands out by their head. You get them to look at your nose and then you turn their head quite fast in an unpredictable manner to either side and ask them to keep looking at your nose. And what you're looking to do is to see if their eyes stay fixed on your nose, which means the reflex is working. Because if you turn the head to the right and the eyes stay fixed on your nose, it means the eyes have gone to the left to compensate for that head movement. So you shouldn't see them move. You should just see them stay fixed because it's a really, really, really fast movement that happens as soon as you start turning their head. If they've got a problem with the reflex and the inner ear pathway is not working, the eyes will initially move with the head, and then you'll see a delay where you get these what we call saccades, which is flick, flick, flick. And I'll show you a diagram and a video of that. So when you're doing your head turns, you want to make sure you do both sides. The abnormal side is the one that you've turned the head to and the eyes don't move fast enough. So it's easy to remember because it's the side that you're turning to is the one you're testing. You want to go quite fast, and it doesn't have to be really far. So if they've got a bit of a stiff neck, you can only just sort of go this far would be fine, but it does need to be quite fast. So this is just a diagrammatic representation of it. So the top one is normal, where the patient's looking at you, you turn their head to the patient's right, and the eyes are moving within their skull to the left, which means they stay fixed on your nose. The bottom one, you turn the head to the right, the eyes move with the head, and then there's a delay before they move back. Make sense?
Sure does. Very clear. Thank you.
Good. And then here's a video. So I'm glad that that makes sense because videos of the head impulse test are a bit of a nightmare to try and capture because of the angles and stuff. And so the one I had that I took that was quite good, as Lucinda knows, when we played it, when we tested this, it didn't work. So I've got this one from a colleague, which is, it works, but you just maybe have to watch it a couple of times. So the little inset is the person doing the test, and then we've got the eyes on camera. So this is the normal one. So that's the abnormal one. So I'll show it twice.
Yeah.
I think they do a couple in the thing anyway. So the first one, there's a big delay on it, doesn't there, when they do it again? I'm sure they're going to do it again. So that's pretty normal. The eyes just stay fixed. And then that one's abnormal. You see the eyes, there's a lag, and then they go flick, flick, flick. Yeah, so I'll play it again now that you sort of know what you're looking for. So the normal one, you don't really see anything happen. The eyes just stay. It looks like they're not moving because they're just doing their thing. But the abnormal one is where you then see the delay and the little flick flicks. So this one here, when the patient's head is turned to the left, the eyes stay fixed towards the right. Head's turned to the right, and the eyes have that lag before they come back to the left. And then a wobble. It's like nystagmus, basically, those saccades. And what those saccades are, the central nervous system getting into gear. So this time, turn to the left, nothing happens, it looks good. Turn to the right, and then we have that delay, and then wobble, wobble, wobble. It's much easier to see when you do it yourself. It's actually easier to see than in the video. Yeah. So does anyone have any questions about the head impulse test? Anything in the chat there about that? No. Perfect. Well, there'll be time to ask about it later anyway. So we've done nystagmus, we've done the head impulse test, which we mainly do if they've got nystagmus. Then we assess their walking, so gait and balance. Can they stand up? Can they walk around? If they've got a vestibular cause or a peripheral cause of vertigo, they should be able to stand with their eyes open, and they should be able to sort of hobble a few steps at least. They might need a bit of help. But if they're sort of lying down in bed, they can hardly even sit up. That's a pretty warning sign that they're not able to compensate using their central nervous system. So yeah, so that kind of gives you a bit of a clue as well. The test of skew, and this comes into play talking about a vestibular neuritis versus stroke question. So that's something that neurologists really like. So basically, it's called the alternate cover test, and you get the patient to look at something in the distance, and you basically uncover and cover their eyes like that, so one eye at a time, while that you're not using both, you just use one hand, but other on yourself, and get them to look at something. And what you're doing is you're looking at one of their eyes, so you can pick the left or the right eye, and it doesn't matter. As you uncover it, each time you're looking to see if the eye goes up or down, so it has that vertical correction when it's uncovered. And if it does do that, that's a sign of a central abnormality, like a stroke or a tumor. If it goes horizontally a little bit, that could just be that they've got an unmasked squint, so that's normal. But if it's going up or down, that's that sort of abnormal neurological finding. Then there's other, your general neurological exam if that's indicated, and I tend to do the 5th and 7th cranial nerves, so facial movement and facial sensation and movement, which are closest to the 8th one, and then do some cerebellar tests, because those are probably where the money's likely to be. But obviously, if they've said they have trouble swallowing or walking, then you're going to test those things as well. Look in the ears, make sure they've not got an ear infection or cholesteatoma, something like that. And then either a hearing test or a tuning fork test to see if they've got a hearing loss. Then I've talked about the blood pressure and cardiac exam, kind of dependent on whether, if everything else is normal and you've not found a cause, you might want to check those things out. Yeah. So the last thing I was just going to do was sort of put those things together that I mentioned at the beginning, this nebulous acute vestibular syndrome, which is this 24 hours of vertigo with nystagmus that we think is hopefully vestibular neuritis, but might be something nasty. The HINTS plus is the way to remember what you need to examine, or HINTS is the way people remember it. So HI for head impulse, nystagmus for N, and then TS, test of skew. And so head impulse test first. If that's normal and they've got the acute vestibular syndrome with nystagmus, that's a bad sign. That's a red flag. If the nystagmus does not fulfill those criteria that I mentioned at the beginning, which is unidirectional, horizontal, not changing directions, and it's worse when they look in the direction of the fast phase. If it's not those things, that's a bad sign. If they've got that skew, so that deep, the up and down movement of the eye when you uncover it, or if they've got a new hearing loss associated with this 24-hour history of vertigo, any of those 4 things would make you want to refer them into neurology or general medicine or get a scan yourself, depending on where you are. So those are the worry signs.
Good
cool.
To know.
So,
plus.
Plus, yeah. So the reason it's plus is the hearing test. Yeah, or hearing. You can ask them about hearing. You're not going to get an audiogram, are you, in your rural ED? But yeah, new hearing loss. So tuning forks, or the patient will usually tell you.
Yeah.
Yeah. So that was. That's right. I was going to talk about the Dix-Hallpike test next, and that is to look for BPPV. So if we think someone's got BPPV, and it's funny the way I had to do these things first, otherwise it wouldn't have really made sense to do at the end of the discussion about the conditions. But it makes more sense when we talk about BPPV itself. But the Dix-Hallpike test is the test for BPPV, that benign paroxysmal positional vertigo. If they've got spontaneous nystagmus or they've got abnormalities of the other things we've talked about already, it's not BPPV, because BPPV is only brought on by this particular movement of the head. So if they come in saying they're dizzy and they've got nystagmus as you look at them, it can't possibly be BPPV as the diagnosis, so you don't need to do the Dix-Hallpike test. You do the Dix-Hallpike if you haven't found any other cause and you think it's BPPV, or if you think it might be BPPV, which by the law of averages, it probably will be BPPV because it's the most common thing. So what you do to test for that is the Dix-Hallpike test, which is where you lie them back, and I've got a much more detailed way to do it later on, but lie them back with their head extended and 45 degrees to the side. And what you see is a few seconds of delay and then this torsional nystagmus that lasts for less than a minute, and then it stops and they feel dizzy with that. So that's the Dix-Hallpike test. So I will talk about those 4 conditions, but is there any questions maybe about the way to take the history or do the examination or anything like that before we move on to the actual conditions? Sounds like no.
No, I don't think so.
Right.
They generally whack them in there as they were
Yep,
going.
perfect.
Cool. Thank
So
you.
BPPV is first up because it is the most common, maybe up to 10% in the lifetime. And I think sometimes it's pretty underdiagnosed, especially in elderly populations. They've done studies on people on the fracture ward, and lots of people have got sort of undiagnosed BPPV, which can contribute to falls and loss of mobility. So what it is, this is a horribly anatomically incorrect diagram, but it does show you the pathology. So remember, we've got these semicircular canals, 3 of which on each side. So this one's the superior, also called anterior. This one's the posterior, and this one's the lateral, also called horizontal. And then in central to this is the utricle, and then the saccule is not even in the diagram. Because the reason they haven't put that in is that these little filaments, these little particles, come from the utricle. So what they are, they're otoconia, they're calcium carbonate crystals or particles. They're not pathological. So we've all got them. They're meant to be there. They sit in the utricle. So they're not in the diagram here, but they're sitting in here on a membrane, which is like a gelatin layer. The membrane has got these particles sitting on them, and they've got a density. And so when we move our head forward and back, or when gravity has its effect on us, the way the particles move and sort of sludge against, shear against that gelatin membrane, they've got little hair cells poking up underneath, and they tip those hair cells. And then that sends a signal to the nerve to say that we've moved forward or back, or there are these translational motions. So that's what they're meant to be doing. They're normal to have them. We've all got these little particles, the otoconia. And that's what they do. What can happen in BPPV with the pathology is that they come off the membrane, so they demineralize off the membrane, and then they fall out of the utricle into the semicircular canals. And usually they would fall into the posterior one because it's the most anatomically easy for them to get into. Hard for them to go up into the superior or anterior canal, and relatively hard for them to get into this horizontal one. So almost always it's the posterior canal, occasionally the horizontal, and pretty much never this anterior or superior one. So they fall off, they get into here where there's not meant to be particles. So in these canals, there's only meant to be fluid shifting around. So with the particles in there, they will just fall to wherever is the lowest point by gravity. And so when the person puts their head back, typically it's like turning over in bed, turning to that side. So if it's in the left side, it's when they turn to the left and put their head back in bed. When they reach up into a cupboard, or they do some work under a car, those kind of things, looking up on a shelf at the supermarket, those things will provoke this movement of the otoconia, sends a signal to the nerve that's at odds with what the rest of your body is doing, which is all normal. So you get this mismatch, which gives you vertigo, and the nystagmus, which is in the plane of that canal. So the posterior canal, you get torsional nystagmus towards that side if you're examining them, and they'll feel dizzy for about 15 seconds or up to a minute. And then as everything stops moving around, it then goes back to normal. But of course, it can happen every time they move their head. So the patients often will avoid the particular movements. They'll just tend to put the extra pillows in bed and not look up to the shelves. And it tends to come in clusters, like they might have it for a few weeks or months, and then it's good, then it might come back again. So that's what they get. I've talked about, actually, sorry, I've kind of gone out of order for the slide, but it's usually idiopathic or primary, but you can get it secondary to various other conditions. So post-traumatic, so bang on the head that helps them move off. Vestibular neuritis, that's what VN is meant to be. So if they've got a sort of a sick, unhealthy inner ear, it makes it more likely that they'll demineralize and move. Ear surgery, Meniere's disease, so kind of any ear condition really predisposes you to it. And actually migraine is more likely in people with migraine as well. So often can be secondary. Vitamin D, low vitamin D, kind of calcium homeostasis problems. So in terms of the signs, as I kind of alluded to before, examination should be 100% normal until you do your Dixwell Planck test. So they haven't got nystagmus, their gait and balance is normal, neurological exams normal, everything's good, ears are normal, hearing's normal, but then you do the Dixwell Planck test and it's positive. I've just put a bit of a kind of a contraindications thing there. I mean, it's hardly ever that you can't do the Dixwell Planck test. I guess if they've got a C-spine fracture, you definitely aren't going to be doing it, but most other people are fine to do it. So what you do, and it's, you can do it different ways. I like having pillows on the bed, so that when they sort of get their head back to the flat of the bed with the pillows under the shoulders to get that extension. But you can also have their head off the end of the bed, because what you want is it to be extended about 20 degrees back from the shoulders. Does that make sense? So either off the edge of the bed, or have pillows there that when you lie them down, their pillows are going to be under the shoulders, like 2 or 3 pillows, so the head goes back onto the bed. It's a bit less scary for patients having it that way than on the end, off the end.
Yeah.
So turn the head 45 degrees first, then you lie them quite quickly down till they're in that 20 degrees hyperextended position. and then wait. And so it can take up to 30 seconds for it to come on, but not usually more than that. They'll feel dizzy. Often what they do is they close their eyes, actually, so you miss the nystagmus. So you often have to tell them, even if you're dizzy, keep your eyes open, and get them to look at you or look at your face or your finger or something. And then you'll see after a number of seconds this nystagmus, which is going towards the ear that you've got down, that you've got it turned to that side, and it's going, the whole eye is kind of going upbeat, and it's torsional. So it's like an anti-clockwise or clockwise, depending on which side it is. And then it lasts up to a minute, but usually it's a lot less than a minute. And I've written there that it habituates. So if you do it again and again and again, it'll get less obvious as you do it over that period of minutes. But it would still be there again the next day. So there's a diagram of it, and then there's a video as well. So the first picture is the left Dix-Hallpike test. So you've got the patient's head turned 45 to the left and down. This one is testing the right ear. You've got the patient's turned to the right and down. So here's a video. So you'll see again, like the last one, like the little thumbnail bit that's got the examiner doing it. And then the main picture is the eyes. Oops. It wasn't me doing this in 1997. So you can see the nystagmus there.
Yep.
You can see it's definitely torsional. It's going around
the
clock face. And when it's really fast like that, it's almost hard to say, is it going to the right or going to the left? But when it slows down, you can see it's going to the right. Then it stops. And then he's going to sit her up, and you actually get a bit of a reversal, like it's less obvious, but it goes the other direction after they sit up as well. And I'll play the video again. You can see it start to flick there, going the other way around. Less severe. So I'll play that one more time, just because often it takes a couple of goes to get used to what you're doing. So right side, so he's turning the head to the right and then down. Nothing happens, she's blinking, and then you get, after a few seconds, this kind of accelerating nystagmus, which is sort of reaches its peak right there. That one's not really obviously upbeating either, but often the whole eye will be going up a little bit as well.
I mean, if you have BPPV, how often is the Dix-Hallpike falsely negative?
Really, if you do the test properly. Sometimes people find it more useful in the mornings. So worse, the patient might get better in the evening. So it's best to see them in the morning. But yeah, if they've got BPPV, you should have a positive test.
Right. Okay.
I can see there's something in the chat. Do you always say, sorry, you were already interpreting that question.
No, well, no, Lisa and I obviously think similarly, but
that's a slightly different question, actually. So that is a good question. So if they're not currently symptomatic, you might not see it, actually. So let's say they get recurrent clusters of vertigo, and the last one was a month or two ago, it'll probably be a normal test, and everything else should be normal in the exam. And if the history is great for BPPV, and the rest of the exam is reassuring and there's no suggestion of it being something more serious, I would say to them, look, it sounds like it's probably BPPV. Come back and see me when you've got, or see someone, depending on where they are, when you've got the symptoms, and would examine you at the time. Yeah.
Great, thank you.
It's all good. So differential diagnosis, migraine, of course, because it's the syphilis of vertigo, can give you this as well. Can present with anything. Vestibular paroxysmia is that, that neurovascular compression we're talking about. So that would not give you the same finding on Dix-Hallpike, but the history can be suspicious, can sound a bit like BPPV. Don't worry about third window condition, actually. Postural hypotension can give you, again, the history can be a little bit difficult, I think. Sometimes people will say, oh, it's when I bend down to do my shoe or something like that. And is it?
Oh, lost her. Just going to turn off your video, Joel. Technical issues. Where's Justine gone? Wait there, team.
Hello? Hello, can you hear me?
I can hear you.
Yay, sorry, I don't know what happened
Hey.
there.
No, that's good. Okay, wait a
Um,
minute. I'll just go
cool.
back into my full screen. Awesome.
Sorry, I think
Hi.
the internet
No,
must
that's
have gone or something. Sorry about that.
no, that's all
Um,
right. You froze. It's great to have you back.
shall I
Welcome
screen
back.
share again?
Yes.
Great.
You can still screen share?
Yeah.
Cool.
Yep. Awesome. I'll just go back to that. Perfect. All good? You can hear me all good now?
Yes, we lost you at the point where you were talking about bending over.
Oh, yeah. It's just saying about like the blood pressure, so it's always hard to tell, isn't it? Is it postural hypotension or is it BPPV? But you can quickly tell on the exam which one it is. So the treatment for BPPV is an Epley maneuver. And what I've put in there is if you are, I know that some of you work in hospitals and some of you work in clinics, GP practices. So if you're a GP, my husband's a GP, and I know it's kind of impossible to assess vertigo and treat it within your 15-minute appointment. So you might want to bring them back for a separate appointment to treat it. And this is a diagram of what the Epley maneuver is. So you have the patient to start off with sitting up straight. The good thing about the Epley maneuver and the way to remember it is that the first stage of the maneuver is the same as the Dixwell Pike test for that side. So this is for someone who's got left posterior canal BPPV because the head's turned to the left. And step one is that left Dixwell Pike position. So you can remember that by thinking, right, you've already started the treatment when you've got them in that test position. And then once you know that you're just going to be going the opposite way, and that will help you remember how to do it. But I've also got another aid memoir for it as well. And so the reason we do this maneuver is basically like treating the inner ear like a pinball machine. So you're trying to get these rogue otoconia that are in the wrong place back into their home, which is in the utricle. And so you can see in these little boxed diagrams why it works. They're just going to fall wherever the lowest point is with gravity. So in that Dixwell Pike position, they're going to fall to about there. Then you wait for about 30 seconds once the nystagmus has gone away. And then you turn the head over to the right side. So you've done the left 45 degrees. You then turn it through 90 degrees so that it's 45 degrees to the right. As that happens, you can see in the wee diagram that the otoconia are going to go down to about there. You wait another 30 seconds. Then you turn them over onto their right shoulder. So once you've started, you're always going in the same direction. You don't go back and forth. So if they've started on the left, you're always going to be moving towards the right. You lie them on their right shoulder with their head facing towards the ground. So just tell the patient, look at the floor, have your nose pointing towards the floor, and they'll be in the right position. As that happens, you can see in the diagram that the otoconia are going to start to fall back into that utricle. Then you wait for another 30 seconds or so, and they might get a bit dizzy here as they fall back. They'll feel that happening. Then you sit them up with their head a little bit down and to that same side, to that left side where the problem was, for about another 30 seconds, just to sort of let a few stragglers settle down. And so they might feel a bit like they're going to fall in that position as well. So the third and fourth stage can feel a bit dizzy for them. It's a good sign that it's done some good. And the whole thing can be reasonably slow. You don't have to do these sort of huge big head movements, except for the third stage where you get them to lie on the shoulder looking at the ground. You want to do that quite fast. And the reason for that is that you don't want them to go into this lateral semicircular canal, so that you want them to go straight down through here, not having time to faff around getting into this one here. So that's the Epley maneuver. So the whole thing, I mean, it technically should take about 5 minutes, but it's always longer by the time they sit there and kind of get themselves in position and make sure. The other thing I've learned sort of over the years is to get them to sit. If it's a left-sided BPPV, you get them to sit on the left-hand side of your examination couch so that there's more room on the right, which is where they're going to roll to. Yeah. So that all happy with that diagram?
Yes.
Like you'll have it, if you're recording it, you'll have that to look back on if you wanted to as well.
Absolutely.
So the next thing I was going to talk about is vestibular neuritis. Unless there's no questions about BPPV, I presume, so far. And again, we can certainly address them at the end. So vestibular neuritis is now called acute unilateral vestibulopathy. What we think it is this reactivation of HSV virus in the vestibular ganglia, kind of like Bell's palsy or sudden hearing loss, sudden sensorineural hearing loss. So you get edema of the nerve and dizziness. So what I'm going to talk about now will hopefully help explain the direction of the nystagmus for people that like to know the reasons why rather than just accept facts. So if we're imagining in our inner ears that we've got, it's quite hard to sort of do over Zoom, but we've got this firing rate. I always do this if Richard Klingen's on here, he'll remember me with my hands, like with like a moose on either side. So we've got these Oh, good. So he'll be able to laugh then. So you've got this background firing rate of the vestibular nerves and nuclei on each side. So if we're imagining at all times there's something going on in the vestibular nerves, when we turn to one side, it increases its firing, and we turn away from that side or the other side, it reduces its firing. But there's always something going on in the background as this resting firing rate. What happens? Let's say we turn our head to the left and the left side fires more. What happens when we turn our head to the left, and if we want to look in the center, is that our eyes are driven to the opposite side from the way we've turned our head, kind of like we talked about before with that reflex. It's not the same reflex, but it's the same idea. If we want to look straight, when the head gets moved to that side with this extra firing rate, the eyes get driven to the opposite side. Make sense? If we want to look in the center.
Yep.
So what happens when you get right-sided vestibular neuritis? So we've got nothing happening on this right side at all because it's the nerves edematous and not working. No firing on the right. You've always got some sort of firing on the left side, which is healthy. No matter where you've got your head, there's something going on. So essentially your body is going to interpret that at all times as a head movement towards the left, because your body thinks more firing on the left than the right. I must have turned my head to the left. So it drives the eyes towards the right, which is the impaired side. I've got this fist here, meaning it's not working. So the eyes get driven this way slowly because it's just responding to the head turn like you normally would, the perceived head turn. But then, of course, you weren't supposed to be looking this way. So you're walking around, looking over towards this impaired side, but you want to be looking in the middle where you're walking. So the brain realizes this, and it drives your eyes back, like what we had in the head impulse test as these saccades, these flicks. So right side not working, body thinks your head's turning to the left, eyes are slowly drifting towards the right, but then flicked back towards the middle or towards that side. So that's why the spontaneousness at the fast phase of the nystagmus, which actually is not the pathology. The pathology is that slow drift, but we always just by convention describe nystagmus by the fast phase, is your body trying to help you by flicking your eyes back. So the nystagmus goes away from the bad side. Make sense?
Yeah, does.
People that like it to make sense.
Yeah. Great.
Cool. So that's kind of just explaining all of that. And I think I've kind of already talked about the pathology that we get in vestibular neuritis. It's that horizontal nystagmus, which is going away from the side of the lesion. You'll feel vertigo. What I've got there, displacement of SVV, that's the subjective visual vertical. You definitely don't need to write that down or know that at all, but it's, I think, very interesting. And that if you get the person to sit in a dark room where they don't have any kind of perception, any visual things to look at, references, and you get them to line up a lighted laser light beam, they will put that 20 degrees off center because of their deficit. And so that's why they feel so rubbish. They're basically always feeling like they're 20 degrees off. And then they'll sort of, their posture often will be towards that impaired side. So what happens? So they get vertigo, unsteadiness, nausea, and vomiting. They don't get any other symptoms, so shouldn't have any neurological symptoms, headache, they don't, hearing loss, none of those other things. Excuse me. So it comes on not always really sudden, like it might sort of come on over an hour or so, but often the patient will say it's quite sudden. And then I often tell patients it's sort of a rule of sixes. So 6 days feeling really rubbish where they've got spontaneous nystagmus and vomiting and they can't walk around very well and they're sort of almost bedbound. Then there's about 6 weeks where they can get back to kind of activities and get around the house. And if they've got a desk job, they can probably do that, but they wouldn't be able to go for a run or do a more difficult job. So they're still not right for the 6 weeks. And then there's about 6 months where, they're still not quite right and they've got to work on their balance, and skiing and mountain biking and those things would be very hard. So it can be quite a long recovery. So it's good to sort of be aware of that for the patient. Then we've talked about all the signs, which is the nystagmus, the abnormal head impulse test, falling towards that side and then tilting that, but without the skew, and they should have normal hearing. So your differential diagnosis is, I've just put all these lesions everywhere. So, central problems, so strokes and tumours and MS, that kind of thing. As I said before, you can get migraine that can cause this. But with migraine, you shouldn't have the abnormal head impulse test. And usually it sort of evolved itself. It's obvious by the next day or two whether it was a migraine or not. Meniere's disease can give you the same sort of eye findings, the nystagmus and things, but it should have resolved within 24 hours. So if it's going on longer than that, then that's suspicious for not Meniere's disease. And then you can get, so autoimmune is very rare to give you this. It would be bilateral really. So I probably didn't even need to put that in there. But infectious labyrinthitis is useful to think about. Again, it's going to present with a septic patient with a sore ear. or a headache, but that can also give you those same kind of findings. So the treatment of vestibular neuritis, presuming it's not all these other things, is vestibular suppressants, so prochlorperazine, that'll help their nausea and vomiting as well as their vertigo. You do want to make sure they're hydrated, fluids, can they get around, are they safe? So some of these people do need either transfer or admission to hospital. Steroids, if you're really bad with it, if people are really miserable, we sometimes give steroids because it possibly will improve, hasten that resolution of the edema. It's sort of not really proven in studies to make a big difference. So it's definitely a neither here nor there with the steroids. But if you've got someone really miserable, that might help them. Then the mainstay of their management long term is actually vestibular physiotherapy. So getting that reflex trained up again. It may well never recover. So if you do, if you were to look microscopically at that nerve, it might always be poorly functioning. But patients compensate really well by kind of getting as much compensation as they can for that reflex, both using that inner ear and using the rest of their systems. So the vestibular physios have got lots of different things they can do for that. And just expectations, patients often get a real fright when they realize it's going to be a while till they can get back to their usual activities.
Yeah, rule of sixes, good to know.
Yeah.
There is a chat, there is a question in there just from
I've got that there.
Stephen. Yeah.
Cyclazine. We usually use prochlorperazine for it. Sometimes we'll use cyclazine as a sort of an extra antiemetic if certainly no reason not to use that. Yep, any antiemetics are fine, but the prochlorperazine is quite good because it's real sort of reduces the actual nystagmus and vertigo as well, which can be quite good. So then I've just written about those danger signs. Again, it's reminding us what we said at the beginning. If you've got this 24 hours vertigo with horizontal nystagmus or with nystagmus that you think could be this, if they've got the normal head impulse test, that's a worry sign. If there's pain anywhere, I always tend to worry a little bit. If they've got the skew, that's a worry. Neurological symptoms is a worry. And then a new hearing loss with the abnormal head impulse test might just be labyrinthitis, but you would want to be scanning that person and make sure it's not something worse. And so talking of scanning, we had a bit of a chat about that the other day with Lucinda. So it really should be an MRI because certainly in the first 24 hours, a CT is not very good for picking up what's going to be quite a small stroke. But I realized that where you are, your main aim, if you think it is a stroke, maybe to rule out a hemorrhage so that you can then get on to different treatments. So it's not a cut and dry. Of course, there's no point doing a CT. If we're in Christchurch, we'd get an MRI because there is no point doing a CT if you've got access to an MRI. But if you've only got access to a CT and you want to rule out a hemorrhage and you're worried about a stroke, for sure. Yeah. So any questions about that? I imagine there probably will be questions about where to send them or what to do or, when to be worried. Is anything that people wanted to talk about for these patients?
We can see if that comes in,
Okay.
Justine. But
Yep.
I think you sort of covered it in terms of the red flags and what should,
Yep.
Do you take? You essentially referral to ENT for any of this? Like, is there any acute referrals to ENT, or is most of this going to come through? Obviously the stroke is going to go gen med sort of stuff, but that's otherwise, right. When would we refer acutely to ENT?
So if you've got someone and you're happy with all of this, that they have got a complete perfect picture for vestibular neuritis, so they've got an abnormal head and toss test, they've got the nystagmus fitting the right picture, there's none of those other worry signs, and it seems like vestibular neuritis, and they're well enough that they can be at home, you don't need to refer them to ENT. But if they need to be admitted to a hospital, then depending on where you are, like again, if Christchurch was your nearest hospital referral centre, then it would be quite appropriate for ENT for that. But if you're somewhere where there's no ENT and there's general medicine and they're happy to take it, then that's probably more logistically sensible.
Yeah.
If you're obviously thinking that there are some of those signs of strokes or neurology, then it's either neurology or general medicine or whatever your nearest, appropriate referral basis. Yeah. I can see there's a couple of chats. I'll have a wee look at as well. Role for beta-histine. So there's no role for beta-histine for vestibular neuritis. Yeah, so beta-histine is for Meniere's disease. So that won't help vestibular neuritis. Speed of referrals. I presume you just mean when would you refer? So I've kind of probably said that if they need acute, if they need rehydration and things, then straight away. If you've got someone that's okay coping at home, but you want some physiotherapy for them, the sooner they get into their physiotherapy, the better, really. And again, you're going to have a very varied availability of physios where you are, depending on where you are.
Otherwise, most vertigo isn't really going to go into ENT, is it?
So
Like,
if there's any question of it, pardon me?
Apart from many years, maybe.
Yeah,
Like,
I mean, what we always say is the ENT causes of vertigo. It doesn't really matter if you miss those and don't find them. The central causes of vertigo are bad to miss. So it's better to, if you're not sure, it's better to go with the ones that are more important, like a vertebral artery dissection or a stroke or whatever.
Worst case scenario. Yep.
Yeah. So if you're not sure, then probably go for the others. But if it is seeming like vestibular neuritis and they just can't cope at home, then totally fair for ENT. I mean, that's, fine.
Okay. Yeah. Good. Thank you.
Cool. So Meniere's disease. So this is endolymphatic hydrops. So extra fluid in the inner ear. So the inner ear fluid compartments that are continuous between the cochlear and the vestibular system. Why we get endolymphatic hydrops is certainly up for debate. And I suspect there's a whole lot of different reasons which may or may not overlap. So I'm sure there's some genetic components that runs in families sometimes, not always. More common in people with migraine and BPPV. So are there some common causes like otoconia getting stuck in the duct that then blocks up and it overflows with fluid, or not overflows, distends with fluid? Is it autoimmune? Is there some viral trigger? Lots and lots of different theories, vascular theories. So there's still sort of conferences every year about all this, but no one's kind of found a definite cause, because I suspect there's a number of different causes for this final common pathway, which is overloaded fluid in the inner ear. And so what patients get is symptoms related to the ear and hearing, and symptoms related to vertigo, because their endolymphatic compartment is continuous between both. So the classic picture, if the patient's Meniere's disease has read the textbooks, it will present with hearing loss, tinnitus, fullness or pressure in the ear around the time of an attack of vertigo, either before, after, or during. The vertigo lasts for about 2 hours. So somewhere the definition is 20 minutes to 24 hours. So less than 1 day of vertigo with some otological symptoms at the same time, and then they come in recurrent attacks. What can actually happen is patients don't get all these symptoms, and they might just get the vertigo without the ear symptoms, or they might just get the ear symptoms without the vertigo. But the classic picture is to get those. The other classic thing to find, if you manage to get a hearing test, which you guys possibly will not have easy access to, but is a low frequency sensory neural loss in the affected ear at the time of the attack. And then what happens over time as the patient's Meniere's disease stays for long, over the years, is that the hearing sort of deteriorates, particularly in the low frequencies, and then flattens out. So it's a hearing loss, a flat hearing loss over the years, to be a permanent hearing loss. So that's your sort of classic Meniere's disease. When you see someone with it, which is very rare because you'd have to see them during that attack, they've got the nystagmus that we talked about before. So it doesn't, it's that unidirectional horizontal nystagmus. I've confused myself and everyone else by saying it may change direction during the course of attack. What I mean by that is it actually might be left beating, and then an hour later it might be right beating, but it doesn't change direction as you get them to look from the left to the right. The whole thing changes direction as the kind of the fluid is shifting around. But basically you're going to see nystagmus, not too much else to find when you examine them. Differential diagnosis is mainly migraine, vestibular migraine. Could be TIAs, which is pretty rare. I've put vestibular schwannoma there, but it's so rare for that to present with vertigo. The only reason I've put that is if you've got someone with a hearing loss and some balance issues and fullness in the ear, that could be a vestibular schwannoma, but it doesn't be fine and then come, and then be fine and then come. So, there's a big difference there. The third window condition, I've mentioned it twice now, so I'll tell you what it is. It's basically where you've got a hole in the bone of the inner ear. So whether you've had congenital dehiscence of the bone or a fracture, which has caused some bone loss. So in the inner ear, you've got abnormally conducting sound and vestibular inputs that are overly interpreted by the inner ear. Pretty rare. Don't worry about it. That's interesting. I can see there's some things on chat, so I'll check that before we move on. Oops.
Oh, some of them they're a wee bit more aimed at me, Justine. So.
Okay.
But
oh yeah. So what condition most commonly produces poorer balance with age? Oh my goodness, so many different conditions. Perhaps we will talk about that at the end, because pretty much any kind of imbalance can do that. Make your balance worse. Because basically, when your eyes are closed, you haven't got your vision to rely on. So you're going to be relying on the vestibular system more, proprioceptive loss. Like if you've got someone with diabetes, then, the feeling on your feet, your vision's going to be affected, all of that kind of stuff. So yeah, I think it's,
you know how your eyes and your hearing, like you have presbyocusis and you have natural deterioration of your vision. Do you have a natural deterioration of your innate
Absolutely.
balance system
Yeah,
anyway?
I mean, if you get a 90-year-old to stand on the phone with their eyes closed, it's definitely going to be harder than a 20-year-old. Absolutely.
Yeah.
So last of all, probably but not least, because it's around so much more than I think a lot of us realize, vestibular migraine. So often it's people that have had migraines of other sorts or have a family history of migraine. There's sort of hormonal elements to it, I think, as well. I've just picked up that it's often people around that kind of menopause age group that seem to get it. And again, really variable about how this can present. You can get positional vertigo, you can get episodes of vertigo with migraine features, you can get episodes of vertigo without migraine features, but migraines at other times. It's quite variable. But you kind of just get a feel that the person's got some migraine stuff in the background. When you see them during the migraine, they may have no findings at all, so no nystagmus, because they're sensing it in the brain, but their peripheral system is fine, or they might get some weird central-looking nystagmus because it's a central condition. So it's mostly on the history, the vestibular migraine, and ruling out, there's no way to diagnose it sort of on a scan or anything. It's ruling out the conditions. So that's sort of the end of the discussions about the different conditions. What I just last couple of slides about when we refer people, or when we recommend you refer acutely, what we've kind of talked about already. So acute otitis media or pain in the ear associated with vertigo, that person you'd want to get seen by ENT or somebody quickly, because have they got complicated acute otitis media? Sudden hearing loss with vertigo. So if someone suddenly lost their hearing and they've got vertigo, remember we talked that could be a stroke, but it also could be labyrinthitis. So you want to get them seen to either get a scan or look to that. Remember the pain in the neck, we're worried about vertebral artery dissection, so get them seen by someone. Then the concerning hints exam, we've already talked about, that would be the neurology or general medicine. And then we've already talked about vestibular neuritis actually, so that's kind of done. I think I know that many of you are not GPs, but for those of you that are GPs, you might want to be referring people to see ENT about their episodic vertigo. And so we'd recommend that if it's really interfering with their life and work, or if it's got associated otological symptoms, then we'd like to see them, or be happy to see them. And the public system is not very quick, unfortunately. And then the last slide that I was going to mention is just the BPPV. So I realize that it feels like quite a daunting thing for some people to manage BPPV and to do the Dix-Hallpike and to do the Epley, and often the patient's quite anxious about it as well. So it's good to have, whether you're at the GP clinic or in a hospital, it's good to have a second pair of hands. You might, the patient might not want to drive themselves home. They might feel horrible afterwards. So, they might need some antiemetics as well. But what you can also use is this BP. Actually, I can't see that on my screen because I've got the other things covering it up, but hopefully you can see the BPPV Relief app, which is an app that's, I think, about $11, that's designed by a really good vestibular physiotherapist in the North Island. Or his son that's the name on it because he did the computer organizing of it. But it's a really good app, and it sort of goes through how you do the test and what you see in the eyes, and then if you do see it, how you go through the treatment of it. So it's pretty good. And that can be just useful if you've forgotten exactly the maneuvers for it. But also the physiotherapists are good at treating a lot of physiotherapists are really good at treating BPPV as well. So that's another thing that you can use for BPPV. So that was the end of the talk. And yeah, I realize it's a bit of a whirlwind going through a lot of different things. I'll see there's a chat there. That was one we already read. Do men get
going? Oh, yep, go, sorry.
Was that what you were going to say?
No, you go, answer that one.
Okay. Yes, men can get it, but is there a condition that is more common that precedes this, e.g. vestibular migraines? Yeah, really interesting. So there's definitely an overlap between BPPV and migraines as well. So definitely a lot of people will get both. Oh, you're meaning persistent postural perceptual dizziness, PPPD, another acronym that sounds exactly the same. Yes, men can get that. It is more common in women. You're absolutely right. And it's more common in migraine. So PPPD, so persistent postural perceptual dizziness, I thought was probably outside the scope of this talk. But that's essentially a condition where you end up with sort of vertigo or even disequilibrium symptoms, so more kind of vague symptoms often, that are there on at least 1/3 of the days is the definition of it. So it's there kind of about half the time. So rather than getting like a terrible episode of vertigo and then they're completely fine, they get this kind of indolent vertigo, dizziness and vertigo, disequilibrium. often it's worse when they're moving around, worse when they're out, better when they lie down. But it's sort of more this chronic kind of thing. And I think of it a bit like, this is not technical, but a bit like kind of chronic pain. After having an injury, you can then get chronic pain that sort of stays around afterwards. And I think it's a little bit like that as a secondary effect from vestibular neuritis, or as you've said there, vestibular migraines or Meniere's disease or any cause of vertigo. Basically, the central nervous system or the pathways between the brain and the balance system get strengthened and heightened with good reason, because you don't want to fall over. So your body is alert to the vertigo, wanting to be aware of it, wanting to make sure you're kind of kept safe. And so what can happen is it can kind of become its own enemy by being there when it doesn't really need to be. And so people get these kind of chronic symptoms and avoidance behaviors, that kind of thing. So usually it's secondary to another condition like you've suggested there. And the management for that is vestibular physiotherapy to kind of desensitize. Hopefully that answers the question you had. And it's more common in women, like you say.
My question, so great, thank you for answering that. With the vestibular migraine, do you always have the
either
headache?
you've frozen or I have.
Oh, can you hear me? Can you hear me? No.
I think you're asking about vestibular migraine, but I'm not sure what the rest of it is.
I was, yes.
Do you want to type it on the chat?
Someone give me the thumbs up if they can hear me. Anyone knows how to do that? Okay, great. Thanks, Megan. And David. Okay, so we've lost Justine again. For once, maybe it might not be my internet that's atrocious. Does anyone have any other questions? I see one other one has come in. Oh, there you are.
Do I need to screen share still, or probably not now, hey?
No, I don't think so.
Cool.
No, I think we're finished. So do you always have a headache with vestibular migraine?
No, you can get vestibular migraines without a headache, unfortunately.
Right.
You can get just migraines, just vertigo.
Yeah.
Sometimes with some photophobia, sometimes with nausea, sometimes with a headache. Yeah.
Okay. So it's sort of more of a diagnosis of exclusion, would you, in that past history maybe of migraines?
You often get a migraine feel, like it's someone that's had migraines before, or they've had motion sickness, or they've got a family history of migraine, and it doesn't sound like it's anything else. So I guess a bit of both, a bit of a diagnosis of exclusion and a bit of a feel.
Okay, cool. Yeah. Any other questions from people? Margaret, I'm just looking up the Leaning on the Fence post blog for you. You can essentially Google that, and it's also on the University of Otago website. So I'm just going to put the link in here for you. Otherwise, if you go into YouTube, everyone, for our webinars, and you just put in Leaning on the Fence post YouTube, you will find all of our webinars on there too. So unless anyone else has got any other questions, or you've got any other burning points that you want to make, Justine, of things that you see in terms of ENT referrals or anything in terms of vertigo?
I thought I talked about the stuff that is the most common things to see. Yeah.
Okay, great. Okay. Well, thanks everyone. Thank you very much for joining us. I don't actually know what the final score was with the football fern, so if anyone's been multitasking, you could flick that into the chat for me. And then just before you all leave, don't forget to do the evaluation form. So it is up the top of the chat, but I'll copy that again. And then if you can fill that out, I would really, really appreciate it. Coming your way again. Usually have my wingman to do all this technology stuff, and I'm not quite as fast by myself. chat, and here we go to everyone in the meeting. But yeah, great turnout. Really appreciate it. And thank you very, very much, Justine. Really appreciate your expertise.
No problem.
Literally last week I had a case of vertigo and I was like, damn, it's just a week too
A week too
early
soon.
because I could not work out confidently which one it was. So hopefully I'll see her again this week and I can
go
work
back
it out.
now. And look, I also realized, sort of an hour to talk about vertigo. I've tried to skip through quite a lot and haven't gone into heaps of detail with each thing just because you can't. But I mean, if you needed another session next year on one particular aspect, I can do another one.
Yeah, no, that would be great. And absolutely, everyone, it's been recorded, so we'll put it up online so you can have a look back around on it and refresh your memory and get excellent hints plus exam going forward for vertigo. Okay, thank
Awesome.
you.
Okay, all the best.